Well, hi everybody. Thanks for agreeing to spend an evening with us talking about some of the new and old laboratory procedures in veterinary dermatology. This, by the way, not a self-portrait. So let's talk about a few things. So I showed this picture. Why? Because this is obviously a pretty darn good tool set. And I think you can see these are all pretty much tools that are old and tried and true and good stuff. However, this is my older Lexus. I actually have upgraded to a newer one, but this is my car. That toolkit would not serve me very well to work on this car. So obviously we have to evolve as things has changed, just like in every other specialty. So let's talk about a couple of things from the laboratories, um, and we're going to start with initially talking about some of the microscopic things. Uh, this is not the microscope that we use in our practice, but this is a scanning electron microscope. Why do I show it? Because this is an older one, and you can still see it makes beautiful pictures. Anyone will probably guess that that is a Demodex mite scanned on an electron micrograph. So I guess the things we start off is what is it we want to see when we talk about microscopy? And from a dermatologic things, sort of the big things that we're going to want to do are scrapings, obviously, cytologies with aspirates, and then cultures. And then, of course, we obviously don't use those for under a microscope per se, but sometimes we'll circle back and why we do think about cultures a little bit with our microscopes too. So the question is, what do we see when we scrape? Well, and it's interesting, has was on the introduction, since I graduated just coming up on 40 years ago. Well, the first 20 years or so of my practice, I mean, treating dogs with demodicosis was relatively common and some very difficult to do. Um, but it was, now in later days we are seemingly are seeing so much less of all our ectoparasites because of our really, great advancements in parasitology, from going from mitaban to ivermectin to now the isoxazoline uh, parasiticides, which are super, super helpful for all these things that we're looking at. But the things we would look for on a scrape, obviously, are mites, two scabies, Kylie and Helodera. I don't know if anyone, I can't see you guys raising your hands, but if anyone's ever diagnosed this, that would be one more than I have ever diagnosed in the last 40 years as in derm. So one thing I've been impressed with, and I have this extern from Ohio State with us this week as a senior student and stuff, and we started talking about, you know, skin scrapings, and they do need to be done properly. And I also was able to, I was teaching a couple of weeks ago at University of Georgia for a week, and again, we talk about skin scrapings, and everyone's like, "Oh, skin scraping." So it's like, but if they're not done properly, you're not going to get good results. So just remember, you have to gently squeeze the skin, and then you scrape until you get this capillary oozing. I don't use a blade. I use these. These are skin spatulas. And the one I use is actually the one in the middle, the one that has sort of the blunt tip and the sharp tip. But I do find that this to be one very, very effective in getting good samples for my cases. And number two, you can't cut an animal with these. So I don't know how many people have seen this. One time when I was in my senior year, one of my classmates almost took the eyelid off a Dalmatian puppy trying to do a scrape by herself. And again, it shouldn't happen, but sometimes accidents do. It will never happen with a spatula. So that's why I like using these. People ask me, well, are they expensive? They're super cheap. I think I last looked, well, I think the last time I bought them, I got them on Amazon, where of course you can get anything. Um, and I think they were like the one I got, it was like $6 or something. They're ridiculously inexpensive. Of course, I do, obviously have to disinfect them in between patients, with our, staff and methicillin resistant staff in our cases. So, but again, super, super good way to get your scrapes safely and getting a good sample. I scan at 4x power. You don't have to go higher when you're looking for mites. You can, and once you find something, but that should be your 4X. And when I do, I often lower my condenser a little bit. That sometimes makes it easier to get this, defined sort of edges and looking at things. To start with there. And when I do find mites, I'm going to look at for the things like, when we're talking now specifically for Demodex mites, what are the life stages? Are they all adults? Are they all, you have a variety of, things such as the, a larva or an egg, like you see here. On this slide here on the left, you have a nice Demodex egg. On the right, a full adult, and then a larval form right next to it. Why is that important? Well, how do you know if your therapy is working? If you go and scrape in 4 weeks and you went from having lots of eggs and lots of larvae to one dead adult, well, then you know you're moving in the right direction. On the other hand, 4 weeks later, if you still see lots and lots of larval mites and lots of eggs, then perhaps we need to rethink our therapy, or perhaps it's not being done properly. So that's, I think, an important thing to do. And just to remind ourselves, what are the life stages? Obviously the egg is the ovum, the larva, 3 pairs of small legs. A nymph will have 4 pairs of undeveloped legs, and the adult with the 4 pairs, 8 of them total, fully developed legs. So that's how you will know. So, no legs in the egg, obviously 6, 8 small buds, and 8 fully developed legs. So this is Simparica Trio. Why would we show that? Because some people felt that Simparica Trio has a slightly lower amount of the Surulana in there. And could that possibly mean we would not have as good a kill with Demodex mites, or any of the other mites for that matter? I think this has actually been disproved. I think people feel like it's not really true. But I guess if you have a dog, I mean, I've now had veterinarians tell me they don't scrape these animals because once they're on, one of these sort of, newer isosceline antiparasitic drugs. And I don't think I think that's, yes, it's highly unlikely, but I would not use that as my sort of, oh, I'm not going to scrape dogs anymore. I definitely think we need to do it. Because also remember too, I don't know, in your practice, but certainly in mine, I have owners who forget to give their medications, or they don't, so again, I do think, don't use this as a, I'm not going to scrape the dog because he's on NexGard or Bravecto or thing. These are fabulous drugs. And for younger veterinarians who never had to deal with this, things like Mitaban way back, which was a horrible drug. It's a great thing. But again, this should not be used instead of doing skin scraping. Scabies, as you know, if you suspect, we treat for it. It's there became, obviously very hard to find these days with so many dogs on these, the newer, drugs. However, anything you see, if you see a mite, if you see an egg, that's a positive diagnosis. But if you even suspect it, then we treat for it. Don't forget our cat friends. We can get, uh, mites as well. That's a case of right here on this cat. We've scraped where you have a Demodex gatoi mite, because that's the short, stubby one. Kind of a close up of it. And showing it next to cat eye, which has a much longer tail than Demodex gatoi. In fact, perhaps even a longer tail than you see on the Demodex canis mite, the dog one. So also remember, Demodex gatoi is the mite that behaves actually much more like a scabies mite. It can be contagious as opposed to cat eye, which is like the dog one, non-contagious. It also can be extremely paritic. Cat eye typically is not. Demodex cat eye we typically will see in sort of an immune suppressed cat, an FIV cat, an FLV cat, cat who has cancer, cat who has really bad, particularly not well controlled diabetes. I mean, that's where we see those. The gateway might just an exposure thing. So I always like to show this, and and I can't see you if you're raising their hand, stuff like that. But if you've seen one of these on a dog, that's Demodex ingi. That's a rare. We hardly ever see it. But we have, when I do, I see it. I typically have seen it in um, sort of the small Shih Tzu Lhasa peaks, And often it's like hair loss in between their eyes and sort of going onto that first part of their the head area there. So especially sort of a greasy sort of uh, seborrheic sort of situation with erythema. I've scraped, and that's where I found Demodex ingi. Again, luckily now still very sensitive to these new medications that we have available. I don't see lots of rabbits anymore. I used to see them more, but just when you do, they can get parasites. And the one that I most commonly see is this one. And I think everyone kind of remembers this is Kylie. And Kylie has these big pincer palps that cause a lot of discomfort. It's a surface mite. It's easily killed by all flea control products. And that's why down south, where I mostly spend my time practicing, dogs are typically and cats are typically on flea control year round, and therefore you don't see it. But I do see it, sometimes in rabbits. Um, and up north, we see it a little bit more. It can be a zoonotic um, mite too. So sometimes I've diagnosed it because the owner comes in and they said that their dermatologist wanted us to check something on their pet. And indeed, sometimes. And anyone wants to make this diagnosis, I can tell you this is gross. It's disgusting. I also find that people love to show me as a veterinary dermatologist all their skin lesions, and it seems to be inversely proportional to how attractive they are. So, not a good thing for me. I don't know how many people in this webinar have seen this, but this is my in 40 years my only case of seeing this in a young kitten that was adopted from the Humane Society. And this is an ear mites. This is actually notoridres. This is the true feline scabies. And I only have the one picture because I only have an N of one after 40 years. And I certainly looked at it. Now, at times, certain areas of the country seem to have this very commonly. My friend who used to practice it in Houston, she told me that she saw this on a very regular basis and was and unlike canine scabies, these are mites are usually very easy to find. That's why I feel like I haven't missed it all these times. And when I did scrape this one kitten, I've found the mites very easily. But again, just not. And we're seeing obviously with the new flea control products that are out there and the cats that are on them too, see it even less and less. I don't know how many people use the hair pluck instead of a scrape, but it's very effective as well of getting samples. And I like to, and this is something we haven't, we didn't do this, 40 years ago, but about 10 years ago, we started utilizing this more. And I know that for me, a lot of my dogs, especially the interdigital space, as these dogs are so inflamed, sometimes when you took a dull blade or a spatula in there, it immediately started bleeding. So you never knew if you really went deep enough or not. So that's why I do find using the hair pluck in those areas um, are it may be superior actually to scrapes in these cases. Um, you can just two ways of doing it. Use a hemostat, grab a few hairs and pluck them out, or you can basically do the old manual, grab them with your little, your fingers and just pull them out yourself. It's that dogs don't typically mind too much. Of course, some dogs, hate having their paws, touched at all and those type of things. But I mean, it's a very good way to, get in that area. Some areas that are difficult to get a blade or a spatula in. And this is a dog we did a pluck, and you can see the hairs come out, and the Demodex mites come right out with it. And you can see here, these are all adults. So let's switch gears for a second and talk about, cytology and dermatology, which is really skin and ear. They're the big two, of course. And what are we looking for? Well, we look for bacteria, we look for inflammatory cells, we look for yeast. Sometimes, occasionally, we'll look for tumor cells. The most common stain that we've used for years is the Diff Quick stain. And, um, there's this is everybody I pretty much knows what this is. What I'd like to remind you is this is not a gram stain. This is a colored stain, but it's not a gram stain. So when people say, oh, I did this stain with the Diff Quick and I saw gram negative rods, I mean, chances are true that that is probably gram negative just based on what pathology is. But reality is you don't know that. That's not, that there is not a ton of gram negative cocci that cause, dermatologic issues. Certainly not a lot of gram positive rods that do either. But you know, don't forget that this is now what the interesting thing to me is what is the correct way to do a diff quick stain? And we have bantered about this. And 2 weeks ago when I was in Athens, I had three residents who I was working with, and 6 students, and I asked them this question, and they all looked at me and they're like, oh, kind of laughed, and then they were like, well, I mean, I guess we don't, I don't know, is it? And will tell you, it's I've done 10 dips in in all three. I've done 10 dips, you know, on the on the fixative, and then maybe 5 and 5 on those before two. I've done, you know, then I talked with a clinical pathologist one time about it. I said, what is? And he goes, well, the answer is it's kind of like in the Saturday Night Live skit. Nobody really knows. I mean, some people say you should do 30 seconds. Just put it in, immerse it, and leave it for 30 seconds. Um, and I think, I think you just have to be consistent with it. But I think that's one of the problems with some of our cytologies is the inconsistency. Because when I've watched my techs do it, I've seen one of my techs sort of do, I think I did 10 and I really didn't. I think that's an issue that we kind of have to circle back to in a minute. So, and the answer is, I mean, the answer is there is no right answer, but I would say just try to be consistent. So the big things for skin obviously is one, bacteria. We're really primarily interested in staph, rarely other. And the big thing in skin, it would be, Malassezia yeast. So when we talk about skin cytology, I think there's always this direct smear versus a tape prep. And that's just kind of what I do. If it's sort of a moisture lesion, I'll use, a direct smear slides. And if it's not, if it's a real dry lesion, then we'll look at using a tape prep. But having trained as many interns as I have over these years and worked with so many students, I cannot tell you how many times I went to look at a cytology they prepared and they're like, we're having problems reading it. And I said, um, did you use frosted tape? Well, we just used the tape that was here. Yeah, yeah. That doesn't work. You have to use clear tape. So that's number one. And you guys all probably chuckle, but if you've seen, well over 100 frosted tape cytologies, you know it happens a lot. Should you heat fix these samples before you stain? And again, kind of goes back to the other thing with the diff quick. The answer is nobody really knows if the right is saying, some people are adamant you have to heat fix. And then you have, how do you do that? Do you use a hair dryer, which is what I do, or do you use a flame, which I've done? Of course, many times we seem to have cooked the samples as opposed to fix the samples to the slide better. So the answer is, I mean, I sort of feel like the hair dryer is kind of splitting the difference because you don't basically fry everything, or cook it, but it is something, that, we don't know. And how long do you, do it for? That's the variable part of this. Um, I think that using 40X on these lesions uh, is often super helpful if you can get it to do it, as far as you have to make sure your slide is set up properly with, a cover slip and using, using your, maybe oil under the cover slip, not on top, but under it, and putting a small cover slip on it, but make sure you don't get oil out. So you don't want oil on your 40X objective. Most of the time, I find with the 4X and 10X, you can get pretty good results anyways. And for a long time, I actually thought this was it wasn't until I went to a dog show one time, I thought this was what a normal Westie looked like. But you can see this is a dog who has a seborrheic oleosa, the greasy seborrhea that you feel that when you're running your hands over this dog, that sort of waxy, feel to him, often with a nice, pleasant odor, which thankfully, as a dermatologist, I'm lucked out. I have very little sense of smell. This is obviously a nipple with a collarette right around it. This would be hard to do a direct smear. So this is a great one that you'd use your tape prep on to look. And we like lots and lots of things with cytology. We love Malassezia are sort of the glamour organism, I guess, for dermatologic cytologic samples. I mean, they stain so nice. They're so fun to look at and stuff. The debate is a peanut, is a bowling pin, is it a number eight, whatever. But they're certainly very classic. But the other question is, does Malassezia live in the ear normally? Of course it does. Does it live in the skin? Yes. That's why when you look at cytology, now you can sort of get a determination if like a culture, and if you cultured an ear and got Malassezia, you would not really know if that was a significant pathogen because it lives there normally. Um, but if you looked at like this cornea site there that's just covered with Malassezia all over it, I mean that's a great slide. So that that's not right. On the right, seeing that much Malassezia in your cytology, that's clearly an incorrect one. And I mean, I'm sorry, your skin cytologies. So now, one frustration you guys have probably experienced because I have many times is what happens on that dog like you just saw that Westie, and you do cytology and you find out that you do everything right, you feel like you build a great stain, you look, and you really don't find any Malassezia, you know. And that's actually probably something that we see that involves Malassezia hypersensitivity. Um, for those who remember back in the days of the flea allergic dogs that were real bad, they had this sort of mid lumbar, triangle that, went back often, with hair loss, often lichenification, hyperpigmentation. We used to call it the Florida Triangle. But if you flea comb them, you often would find really zero fleas, one flea, two fleas, as opposed to some dogs who have normal skin, and you might flea comb them and find 40 fleas on them. Those were not flea allergic dogs. I think the allergic response often lowers the numbers of these organisms or these, the fleas back then. So, still, if you suspect Malassezia is kind of like scabies, I think if you're suspecting and all the signs fit, then don't be afraid to use an antifungal shampoo. Don't think maybe it's bad enough you need to use an antifungal orally like terbinafine or ketoconazole or fluconazole. This was actually from on a tumor that we did a direct smear, and of course this is a mast cell tumor, round cells, the granules and stuff. An eosinophilic plaque on a cat. You can see all these eosinophils everywhere. So a quick way to make this diagnosis. Um, we did not have to biopsy this cat because it actually looked like cancer on this cat's belly. And I thought, but let's just do a direct smear just to make sure that we don't see these aren't really angry eosinophilic plaques. And sure enough, they were. Uh, in the 1920s, Arnold Zank, I'll show you a picture of, developed this thing called the Zank prep. And it's the aspiration of an intact pustule, or if none are available, you might be able to do it under a crust. I will tell you that's a little bit harder. But this is a way that we look for. We want to look for these and see what we see. And what we're looking at is, and that's Dr. Zank, and he was actually a hematologist, not a dermatologist. But this is what we look for. These are acantholytic cells. They're not acanthocytes. That's the blood cell term. These are acantholytic cells. These are the cells that have lost their adhesion and they've rounded up. And then you'll see lots of these hypersegmented neutrophils, but they're not toxic neutrophils. They're hypersegmented. And what you don't see, bacteria. You don't see intracellular bacteria in any of them. So this is a classic Zank prep. This is something we'll see in a dog that has pemphigus, a pemphigus foliaceus case. In this case, but all the pemphigus are associated with acantholysis, and so it would not be impossible to see that in any pemphigus case. Pemphigus foliaceus is the most common. It's probably the one you're going to see and diagnosis the most. So the ear cytologies would be next. And we obviously want to look at bacteria versus yeast, rods versus cocci, intracellular versus extracellular. And this cytology is more valuable than ear cultures. I would tell everyone in this time, I have not cultured an ear in so many years, I couldn't even tell you how many. Ear cultures, especially external ears, are basically useless. I mean, they're not, they tell you things that actually lead you astray because everyone calls me and says, oh, I cultured a Pseudomonas and it's resistant to everything. Well, first off, if you're planning on using the sensitivity pattern, that's only based on blood levels, right? So it has nothing to do with with topicals, which is most of the time thousands times higher than that MIC was. So that's why I would say, I mean, we don't culture. If I was going to culture, it would be when and it's really better, in the cases if I have middle ear disease and I'm going to do a myringotomy, I take a sterile um, through my video otoscope. I will take a sterile Tomcat catheter, pierce the pars tensa, and go into the middle ear, flush and suction out with just a small amount of sterile saline, and I would culture that. If you did a bulla osteotomy, if you are capable of doing that, culturing inside, because then you would, and then you could make a sensitivity that then you're using systemic antibiotics as well as topical, if that's your case. I still treat most of my otitis media cases with just topical, aggressive topical antibiotic therapy, to be honest with you. It's not common that I use systemic antibiotics. So don't do, I mean, I would tell you, if you're up to me, I would take your cultures off the labs wouldn't even offer them anymore. Also, when you look at sensitivities, that's based on if with Pseudomonas, and some of the ones that produce biofilm, it might be great that an antibiotic might work, but that antibiotic have to get there. I mean, a lot of times they can't get to the organism to kill it. So that's another issue with the culture. Other things too, a number of years ago, a really great study done by Dr. Nicola out of Ohio State was, and she cultured multiple spots in a diseased ear and got basically different results in every spot she cultured. So again, I think I would save the money for the cultures and put out all that money into cytologies, because I think you should also do those sequentially as you treat. It would not, like I said, do not do cultures in my opinion. Also, don't be like I sometimes was and did some and made the mistake of, you look at something, you think, oh, that's a yeasty ear. Look at the brown, sort of waxy. And that's the stain that I did. That's clearly not a Malassezia ear. That's a bacterial otitis right there. You can see the degenerating neutrophils and all that protein, as well as bacteria. And you don't see a lot of yeast. And I would have bet $100 when I took the sample out of that allergic dog's ear that it was just going to be a Malassezia ear. So, sure, if you dip it in there and it comes out just pure pus, it's probably, probably feel pretty comfortable. But sometimes you can be, um, you might find something else. Now, this I think is interesting because you guys might laugh and um, obviously the air mites. Um, I had to, I gave a lecture and I said, I never see ear mites. I haven't seen ear mites in so many years because you guys don't refer to a dermatologist ear mite cases. You guys, treat them if they're not hard to find. So I started that picture was one I took like 35 years ago. And then so one of the people in my class that are in the lecture said to me, she goes, oh, I have a really cool video of of ear mites I just took like 2 days ago. She texted it to me, and I incorporated that. Like I said, that's something that I don't really ever see in dermatology, specialty practice. Um, However, again, just like all the other mites, they are very sensitive to the new isosceline antiparasitics. This is kind of interesting. If you look, I don't know if you can see my arrow, but up over on the upper left, these weird cells, um, with all the, the nuclear stranding and the proteins and the bacteria. So, but those weird cells, those aren't so turned out. Um, those are actually tumor cells. We could diagnose and look when we cleaned out the dog's ear better. We found the dog had a squamous cell in it down in the ear canal. So again, just like don't take their samples, but don't just look at them and make your diagnosis. Take stain it, and make sure you're not dealing with something else. Which now brings up something that, Zomedica has, the TrueView microscope, and Zoetis, of course, has the Imagist. This digital microscopy is, I think, really, really great. Um, I, of course, have not used the VetScan Imagist system. But I have done a lot of work with the TrueView, and I think they're both to have, provide great images. But I also will say why I think that I like the TrueView better. And that's because of this. Well, one, easy to send, both of them will do this. The easy to send, samples out to get a consult and get an answer back very, very quickly. Um, but the other thing is, the TrueView takes this sort of variability out of out of the staining. And so, again, none of my techs who are all certified techs all know how to stain, but they all do it seemingly differently. But they all know how to put a sample. Obviously, that was a hematology sample, which we don't do in-house here. But we do, they all know how to put a slide, your smear or a skin sample on a slide and put that in. And then the next part is, um, oops, this uh, automatically goes in. So it takes all of that. It smears it for me. It I mean, well, it stains it evenly, and then starts its scanning, and then, after a period of, usually 5 minutes or so, we can look either on the scope itself, or we can look on the I just have myzoonomedica.com, and my TrueView samples all my cases right up there, and then I can just go and look right on my computer, and it's great for documenting. I put the, I take those pictures, put them in the medical record. I send them to my owners. I send it to my referring veterinarians stuff. So I do like this. And I think, again, that's the difference. One of the, big differences, is between the two, is that in the images, you still have the variability of who's staining it and how they stain it. This one takes that variability out. That's what I like that the best about that. I also like the fact that and I've been involved with Zomedica's TrueView for, since it basically was released, and it's been, they're always, logging in, updating my software. They, have updated my machine before, so it's a, very consumer friendly company to work with. I don't know how many people do in-house cultures. We did some, and every now and then we'll do it. But I will say this: I think um, it's still probably one of these deals that you should consider sending out to the lab. When we do these, we do Kirby Bauer disc diffusions to do our samples. And this is it's just will show we have these color spot slides that sort of differentiate between gram-negative and gram-positive organisms. And then we'll, use those to do get our sensitivities. But the Kirby Bauer sensitivity, although, what we used for years, it's clearly not as good. And we can't do as many sensitivity as we can with an MIC. So I'm not pushing for this, but dermatified cultures. Here's another thing. I'm not really pushing you guys to do these yet in clinic either, because unfortunately, I don't think many people have problems with them. We don't do them. I will tell you, and I was in vet school. I basically was the microbiologist at University of Florida for 2 years, and did all the cultures both after school, and um, and I'm very comfortable in differentiating dermatophytes and things. But I'm also sometimes have forgotten a culture was in a drawer, or a place where they're not lit up, and next thing you know you have it's like a week has gone by. Just remember the alkaline metabolites turn the media red, but all the organisms, all the fungal uh, cultures will turn it red eventually. To do them properly, we usually use a combination of hairplex, scale, Mackenzie brush. Now, of course, we have this PCR, which is really, really great. I don't use it instead of cultures, but I use it in combination. And I think it's a really good system to use. But if you did do in-house cultures, I think the plates are much easier to work with than the tubes. So I would be really pushed to use the germ plates like this. This is obviously Microsporum canis, the white fluffy colonies. Please remember, if you're looking for dermatophytes, they only come in sort of the two colors, white, off-white, tan. They're never blue. They're never black. They're never green. You see that on your plate. You don't have to really differentiate that out or speciate it out because it's not a dermatophyte. They don't come in that color. But that's what, again, and this is with a lactocotton phenol blue stain, which most people don't have. But that's the macroconidia of Microscopic canis. More than 6 compartments, a thick walled Microsporum gypsum, six 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 compartments or less, and very thin walled. Some people say, well, what is it? Why does it matter? Well, it matters because you might want to know where your animal is getting it from. If the dog has Microsporum canis, is there a new kitten in the house? Is there is the dog going to a daycare? Is it going, is it an immune compromised dog? Why did he get it now? If it's a 13-year-old dog, now I might be thinking, why did you just get a dermatophyte infection now? Maybe you have cancer or some other immune compromising disease or Cushing's disease. M. gypsum, which by the way I think does have a new name now, is a soil organism. Is it a digging dog? And that's why we often see M. gypsum infections on this nose of longer nose breeds, labs, some dogs who like to go be outside and dig and do crazy stuff. Also, trichophyton species are much harder to differentiate, but that's what we sometimes see with rodents. I had a horrible case of it one time in an atopic terrier who had pemphigus foliaceus and this raging dermatophyte infection. Well, that all started coming from they had adopted a guinea pig from a store, I guess, paid for it. Anyways, that guinea pig gave the trichophyton mentagrophytes infection to the dog, the little girl who was, the guinea pig's owner slash, and then both parents got it. It was a mess. So yeah, speciating is important. You know what? You have better things to do than try to mess with that. Send it to the lab. Have them, make sure you use a good lab. Well, some labs are better than others, but send it to the lab with your PCR, and so that would be what I would recommend. Uh, we don't do in-house um, CBCs because we don't do that many of them, but obviously you can do them with both of these Microsoft systems. What do we look for when we are looking for, anemias, anemia, chronic disease, elevated eosinophil counts, elevated white counts. So that's for those, who are using that, certainly another great option. Chemistries, we don't, again, we don't do see a lot of stuff in derm on the serum, but don't be surprised when albumins can be low and chronic skin disease or globulin can be elevated, especially if there's a lot of inflammation. Albumin, sometimes we have leakage of of albumin through, the diffuse wounds that we may see, or these, ulcerations. Um, but, we certainly see ALT, ALP elevations with our Cushing's dogs, dogs who have been on, we obviously have lots of dogs who are on steroids, so we have to look for that. Apoquel and some of the other, drugs we may be monitoring, liver enzymes as well, although they're certainly not as bad with the newer like JAK inhibitors like Zenrelia and Apoquel. So, but this is another thing that we're using a lot, which is the True Forma, also from Zomedica, and I think this is as cool as the digital microscopy, because we can get endocrine results on patients that are super accurate and very, very quickly. Um, this was the initial things. We could do total T4s, TSH levels. We never used to be able to do canine TSH levels accurately. Um, TSH for cats, we don't do it as much because we don't treat a lot of hyperthyroid cats, but free T4s, cortisols, and um, uh, the ACTH levels, which I think is really, really important to do. Now, they've also expanded this into um, the GI panels, as well as the new heart panel too. So I think we really like using this a lot. Super easy to do. Just remember on. So one of the first case, actually probably the first case that we really made some difference was a thyroid case. So let's just review real quick. What are we looking for? So remember, the hypothalamus secretes TRH, which then goes to the anterior pituitary to release TSH, which goes to the thyroid gland to release, T4, which is then converted to T3. And you can see that you have this negative feedback system. Well, like in people, if you go to if they're going to measure your thyroid, what do? They measure your TSH level because it's so, so accurate, much better than just measuring a T4 or free T4. But we were never able to do it. Now, not only can we do it accurately, we can do it in 30 minutes and stuff, which brings in Barley. Barley is an atopic dog who is a cocker who had a super stenotic ear canal that had, but an owner who did not want to ablate it. And I tried to convince her it was the best thing to do for Barley, but she had to have nothing to do with it. So we worked with her for over a year, and we actually, through her hard work and sort of in spite of me, I think, this ear canal actually we got it open again. So we used progressive topical therapies and with steroids. But one day she came to me and she said, I think Barley is hypothyroid. And I was like, well, thank you for that. I'm glad to see you're utilizing your Dr. Google degree. And she goes, no, I just think he's sort of quiet and depressed. And I'm like, clearly he's not hypothyroid. He's just an, sort of middle-aged, cocker. And so, but I said, but you know what? I'll humor you. I will measure his TSH level and his T4 just to prove to you that he's not hypothyroid. So here's his TSH level at 0.86 with a reference range of up to 0.51. And I measured his T4, which was unmeasurable. So Miss Henry was right. I was wrong. He was, and he's done unbelievably well on his thyroid replacement therapy, in addition to his hyposensitization, and in addition to his now only topical steroids in his ear to keep his ear open and stuff. So sometimes the Dr. Google knows best, I guess. This is something that, years ago when I was teaching at University of Pennsylvania, when we looked into trying to measure endogenous ACH, the only place that could do it was University of Tennessee. We had to overnight it, of course. It had to be on dry ice, not regular ice. So you had to send somebody to the store to get dry ice or whatever. And usually by the time they got it, they always told us, oh, it was not frozen enough and it didn't work. Um, but it certainly can indiffer. This is a great thing that I love on my Conforma, and that's I do a lot of these. I mean, it's a great system, easy and fast to get it. Is it more accurate than a low dose Dex? It's in my mind, sometimes I think it is. The reality is you can see false, results from measuring ACT. And not the machine's doing the right thing, but sometimes dogs, don't have elevated ACTH and Cushing's disease. But I still think, like I said, I think it's an interesting and a great screening system. First of all, I can do this in 25 minutes or whatever, as opposed to an 8 hour low dose stack. So if I do this and I see what I want, then great. If I don't, I may say, okay, now we are going to do a low dose stacks, or if we may consider doing an ACTH stem. But of course, you can do all of those in house because it'll measure cortisol levels as well as endogenous ACTH. This is a cushingoid dog, and you can see this dog has calcinosis cutis. You can see how thin the skin is. That's why he has what we love to call phlebiectasia. That's that accentuated blood vessels. And that's not, their blood vessels are the same. It's just the skin is so thin. That's why you can see them so well. Just close up of some of the calcinosis cutis. Just remember, this is extremely critic. And sadly, this is a case, a different dog here with the rat tail that we will sometimes see in both thyroid disease and Cushing's disease. This is a cushingoid dog. And both these cases had allergic disease, and they got repeated depomedrol. We went ahead and measured endogenous ATGH, and the levels were very, very low. And we did a stem on them, and they were both blunted to basically non-measurable either. So, one, don't use depomedrol in dogs, please. Two, be careful when you are using steroids, no matter what. I have seen cushingoid dogs just from topical steroid uses, especially if people use their own. If you have anyone who has psoriasis and they have very potent topical steroids at home, sometimes they think, oh, my dog has a little red rash too. Let me put my class 1 steroid cream on it. And next thing you know, you have a cushingoid and calcified dog skin. Finally, I thought when we're talking about labs, I do think dermatopathology is one of the greatest things we have, but it's also one of the more frustrating things especially in the primary care world. How do you make sure? So in essence, if you want to get a good sample and a good answer, make sure you're giving a good sample. So what does that mean? Never, ever, ever scrub a dermatopathology case. Never scrub the skin lesions themselves. Now, if it's a tumor, and you're doing like a deep punch or whatever wedge, I mean, that's different. But if you're talking about a a skin lesion, like that calcification case that we just saw, the calcification cutis case, you never ever want to scrub anything. If there's any question, don't scrub it. That crust and superficial layers often hold the diagnosis. Use a sharp punch, and they are not, I mean, these are disposable punches. I know as veterinarians who love to reuse stuff over again. Don't. They're one and doneers. They do not use them over and again. Now, one controversy is, can I turn the punch one direction or can I go back and forth? I had a dermatologist tell me, oh, absolutely. You can only do by turning it one direction. I, for 40 years, have always done this sort of back and forth motion with my punch. And I asked my pathologist, and actually there's two different dermatopathologists who read slides for me over my career. I said, is there ever a problem with me doing the way they're like, nope. You have, so just make sure use your skin being taught, and use your punch. But when you do it, I always tell, people, you have to bury the punch. Don't start, stop, start, stop. That's where you get artifacts in your lesion. Make sure once you start, you're going to go until the little biopsy cup is completely, into the skin, and, the plastic is touching the skin. That's when you stop. Then, please, 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 I've read slides for years with pathologists and seen this over and over again. Take a small forceps, grab from the base. Do not put a big rat tooth forceps lesion right in the middle of the biopsy punch. Lift from the base, and then use your Metzger scissors to just snip from the bottom. And if you want to put them in cassettes, you can. I don't. Some people like floating them. Stick them on tongue depressor pieces, and then I've never done it. I've always just done them just in the, 2 or 3 Um, and also make sure the pathologist, I mean, the pathologist would want you to use a 44 millimeter punch, so you basically put the entire dog in there. Um, but if you do a 2 millimeter punch, it makes it very, very difficult to see. I mean, there are times I've had to do it. I mean, there's just, when you're trying to biopsy an eyelid on a, 4 pound Yorkie, you can't use an 8 millimeter punch. But use a 6, use an 8 as your primary skin punch biopsies. Every now and then, if you have to use a 4, but it's really don't do um, really small punches. And then make sure the pathologist who's going to read your slide request to have not necessarily the dermatology service per se, but have it someone who's interested in skin if you're not sending directly to a dermatopathologist. There are several great ones out there. I will just throw out mine, Dr. Karen Trainer of Innovative Vet Path. She's fantastic. University of Pennsylvania, where I used to teach. They are great there too. But request to make sure that the dermatopathology people review your slide. You're going to be much happier with the results, but provide them enough, right? 2, 3, 4, samples, 6, 8 millimeter punches. Don't mash up, don't um, do the make sure you handle the punch correctly. This is a pemphigus foliaceus case. You can see if you would scrub that lesion, you would have removed the diagnosis in that very top layer. That's a subcorneal pustule with acantholytic cells and hypersegmenting neutrophils underneath it. And the epidermis is thickened and spongiotic or edematous. And you can also see down below, those are 2 hair follicles. So this pustule is big. It's not a folliculitis because it's spanning 2 hair follicles. So this is a really good case of pemphigus foliaceus. But again, you have to handle it properly. If you would have scrubbed this lesion, pathologist could never made this diagnosis for you. Well, these are my doodles. I initially poo-pooed the whole idea of the whole doodle thing, and now they slowly won me over, and that's Kona, and who's Barb's dog, and he's actually her little service dog, and that's my Alvin. He's a Cavapoo, and he's amazing.